Mrs. R is a 75-year-old Caucasian female, full code, chief complaint of generalized weakness, onset 2 days ago. Patient was brought into the ED 2 days ago via EMS from nursing home due to generalized weakness. While in the ED, troponin levels were elevated with EKG demonstrating ST depression in leads 2, V4, and V6, thus cardiology consult, and cardiology has been on board for about 2 days since the admission. However, patient denied chest pain, shortness of breath, or any other symptoms. Patient denies precipitating factors and describes as generalized weakness onset 2 days ago. Patient was recently deceased from long-term hospitalization at PMH secondary to cholecystitis, end-stage renal failure, septic shock, and demand infarct. Earlier during this admission, patient did receive a transfusion of 2 units of PRBCs due to hemoglobin of 7.5 and hematocrit of 27. Patient seems to have tolerated this transfusion well. Past medical history includes CAD with CABG in 2008, hypertension, anemia, AFib, end-stage renal failure with hemodialysis on Monday, Wednesday, Friday, diabetes type 2, PVD, hyperlipidemia, and depression. She does have a past surgical history of CABG in 2008, cholecystectomy, a feeding tube which was removed in 2013, a right BKA, appendectomy as well. As far as her social history, she currently lives at MV Nursing Home. She denies any alcohol, tobacco, or illicit drug use. Current medications include aspirin 81 milligrams daily, Lipitor 40 milligrams PO daily at bedtime, Plavix 75 milligrams PO daily. She is on Levemir 20 units sub-Q daily, lactulose 20 grams PO BID, metoprolol 25 milligrams PO BID, and pantoprazole 40 milligrams PO daily AC. She does confirm having the flu and pneumonia vaccines in December of 2014. Some pertinent labs include hemoglobin 7.4, hematocrit 31.8, sodium 131, chloride 89, potassium was 4.5, BUN 22, creatinine 3.4, her GFR is 13, glucose of 80. Troponin I is 0.15, and troponin T is currently at 0.1. In regards to review of systems, generalized weakness, no fevers or chills, head and neck, no headaches, no loss of consciousness, no dizziness. Her skin seems intact, no rashes. Her hair seems to be growing normally as well as her nails. She does use glasses, however, they weren't accessible at this time. No history of trauma, no visual changes, no hearing loss or discharge noted from her ears, no difficulty with smelling or discharge. She does wear upper and lower dentures, however, no voice changes or sore throat. Her lymph nodes were not swollen, chest and lungs. She does have a productive cough with yellowish phlegm, onset about a week ago. No shortness of breath though. Denies any chest pain. There is some swelling to her left lower extremity. She has had a poor appetite times 2 days, no abdominal discomfort or change in the bowels though. She does not produce any urine due to her ESRD. She does complain of some joint pain to elbows and wrists. She does have some decreased sensation in her fingers and tips. As far as her mental health, she does have a history of depression, but it seems to be controlled right now. Upon physical exam, she is alert and oriented times 4. She does follow appropriate commands, is currently receiving hemodialysis. During examination, no acute distress. Her current vital signs include 97.1 Fahrenheit, oral temp, blood pressure is 138 over 58, heart rate of 68 beats per minute, respirations 18, 97% O2 set on room air. Head was normal cephalic, no masses, no lesions. Patient normally wears glasses. Like I said, they weren't accessible at this time. Her pupils were 2+. Perla was noted. No edema noted. Conjunctiva was slightly pale. No discharge. No extra exudate noted. Extraocular movements were intact as tested by the 6 cardinal visual fields. Position of the ears were aligned. A small amount of cerumen noted in both ear canals. No obvious signs of hearing difficulty. Her nose was midline. No discharge noted. She did have a productive cough with yellowish phlegm. Lips were pink and dry. Tongue red and midline. Patient uses upper and lower dentures. Her neck was midline. No deviation noted. Denies pain or dizziness with rotation or flexion of neck. No swelling noted to lymph nodes. As far as her respiratory, denies any shortness of breath. She does have a productive cough. No retractions. Chest movement was symmetrical. However, rhonchi was noted to bilateral lower lung fields, and the chest X-ray was ordered at this time. She does have a Quinton cath to the right upper chest for hemodialysis, which is accessed at this time. No redness, swelling, or other signs of infection noted. As far as her heart sounds, S1, S2 were auscultated. There was a mitral valve regurgitation noted. Current EKG displayed sinus rhythm at 65 beats per minute. Seems to be controlled. EKG from ED displayed ST depression and leads 2, V4, and V6. No signs of AFib at this time. No JVD noted. No bruit noted in carotid artery. Abdomen soft, non-tender, without masses. Bowel sounds times 4 quadrants. Bilateral upper extremity, non-tender and symmetrical in sounds and size. Bilateral 2+ radial pulses. Right BKA, no swelling. 2+ popliteal pulses. Left lower extremity, 2+ pitting edema. 2+ pedal pulses on the left lower extremity. No clubbing or deformity noted on her nails. Patient is wheelchair bound, however is receiving daily PT. Patient's shoulder shrug was symmetrical. Her genitalia and rectum was deferred at this time, however denies having any decubitus ulcers. As far as my impression, she does have a history of hypertension, anemia. She is status post-CABG. Elevated troponin and EKG changes secondary to demand infarct. There is a possibility of her having pneumonia just due to her productive cough as well as her rhonchi noted to the bilateral lower lung fields. The plan right now is to arrange for a coronary angiogram. Cardiology will stay on board to continue to follow the patient's progress throughout the hospital stay. Continue have EKGs done daily, and ensure that patient does not have any cardiac problems during hospitalization.